And I'm getting full sense up. And I'm not sure who this particular participant is, the one that has many letters and numbers. If that person would like to introduce themselves. Oh, maybe that's you, Agnes. Are you D9RMIK? Here's a very long, sorry, Agnes is texting me about the fact that she is on this list of participants, but I'm not sure. So whoever texted, I'm not sure, is the person that we're not sure who they are. Let's see. Okay, well, I'm not sure who this person is, and I'm not sure if it was Agnes. Agnes says she's calling in, but I don't see her listed. I guess Agnes would be Purdue. Oh, I mean, this is Aggie and Purdue folk. Okay, thank you. I was like, usually Purdue calls in for this, so it probably is them. It's probably some long list of people. I know Dr. Hokamp is on her way in to also be here, so she'll probably walk into my office in just a moment. And then Dr. Leonard, who is the resident on the case, is coming back from Employee Health Services, and she will try to come to this as well. So in the meantime, I'm going to share a screen and actually do a little plug before I do anything else. Where do I want to share? Maybe this one. Let's do this one. Okay, share that. Share that one. Share. Okay. Dr. Hokamp just walked in. Okay, Dr. Hokamp says hello. So first of all, for those of you guys who are pathologists attending this, do you mind shutting my door, Jessica? I just wanted to give you guys a little update. I know that we have tried our best to create a visual guide for kidney disease, mostly proteinuric kidney disease in dogs. And I just want to see, are you guys seeing the Atlas of Renal Lesions and Proteinuric Dogs on your screen?
Yes.
Okay. So we have had this atlas in existence since April of 2018. And then we decided that authors decided that there were two kind of large topics. One topic was pretty small and the other topic was pretty large, which we wanted to include in this ebook. So the great thing about ebooks, if anybody ever wants to write a textbook, do it this way, because we were able to just insert a chapter where we thought we needed to. So I'm going to let you guys quickly see what the new updates have been. We only have one case to discuss today, so it's not going to take too long. This ebook is focusing on glomerular disease mostly, but proteinuric kidney disease. And the chapters that we have already had in existence have been some immune complex diseases, membranous and membranoproliferative. We also have amyloidosis and focal segmental glomerulosclerosis. And then we have inserted a new chapter, which is juvenile onset chronic kidney disease. It's also referred to and sometimes as juvenile nephropathy. And then we a little bit modified miscellaneous glomerular diseases. So, both of these are kind of changed from our previous version of the book. This part right here was probably the longest amount of work I have done for a long period of time. So I'm quite happy to have said publish. And I do encourage you guys to use this, especially for those of you who are studying for boards, pathology boards. This is probably better than what is, a couple of pages in Jebb and Kennedy. This is an entire chapter with lots of photographs. So I think that this is probably a better, more comprehensive, and a little bit more understandable, approachable way that we look at juvenile onset chronic kidney disease. At the beginning, please realize that not all of these dogs will be proteinuric, and this is an atlas for proteinuric kidney disease, but that doesn't really matter. We get a lot of kidney biopsies to the IVRPS because the clinician suspects quote-unquote juvenile nephropathy or renal dysplasia. This is that old term of renal dysplasia, which we're trying to revamp with a more understandable CKD in dogs that are very young, and that might behave differently than CKD in dogs that are old. So we start with hereditary glomerular diseases. These are actually the similar material that was already provided. We had this stored in the miscellaneous chapter, and then we brought it forward to the juvenile onset chapter. These dogs will present young. The dogs in all these histories are, less than 2 to 3 years. And so they present young, and if you get a kidney biopsy or an autopsy sample from a young dog, this is the chapter you should head to. It doesn't necessarily mean they have dysplasia. They could have something like collagenofibrotic, which is this disease. And we can diagnose that based on the banded collagen fibrils. They could have Alport syndrome-like nephropathy. And again, that has gone through a large number of variations in the name changes, but they're similar mutations. They're a disease caused by mutations in type 4 collagen. And so that's that group of diseases. Again, a lot of these references you could link to immediately if you so desired. That chapter, that material has been moved to this chapter. Again, most of the time, these dogs, especially Dr. Lees can speak to this, these dogs, especially the males, are, an end-stage renal disease by month 6, month 7, month 8. So these dogs present young, and that's why you would go to this chapter. And then we broach the topic of juvenile onset chronic kidney disease due to renal maldevelopment. And this is what used to be the term of renal dysplasia. We don't like that term, and I shouldn't say we. Most of the group didn't really like that term. We really want to imply to the clinician that the kidneys just never developed well. So we have these gorgeous images that University of Georgia made for us. And if anybody, I'm actually not able to see. Let me see if anybody's doing any chat stuff. Anybody doing any chat stuff? Make sure chat. We have one thing. Oh, we got everybody. Okay, good. Back to this. So the UGA people did this really cool, motion animated. Look how it's growing. This is so neat. Then these things are going to condense around that epithelial tissue. This is all epithelial cells, and these are all mesenchymal cells. And then they are going to then undergo mesenchymal to epithelial transformation. It's basically almost kind of think about, we always talk about EMT and cancer, epithelial to mesenchymal. This is the reverse, and this happens during development. And then they go out and they become the rest of the nephron. So they're going to become all the tubular portions, whereas this part here is going to be collecting duct, and these are all going to be the tubular sections of the nephron. And then this vasculature is going to grow in and basically induce these cells to become podocytes, and then it's going to make the formation of the entire glomerular tuft. And so all of this is kind of a neat animation for how the nephron develops. And I'm just amazed that they did this. It's gorgeous. So all of these kind of quick pictures are here for the textbook, but if you really want to see the animation over and over again, you can keep playing. It seems that yes, Candace, you are correct. So Candace has pointed out that the downloadable files have not been updated. You are correct. I have to go through and not reformat everything, but I have to I have to click buttons in the website so that the downloadable files will be updated. I only released this online yesterday, so I'm going to do that probably at the end of the week. I'm just hoping that if somebody finds some more typos, I could correct them beforehand. But you are correct. I wouldn't click download for a couple of days, and I will probably do a big hallelujah email once I'm ready for the download version. I'm going to send it out to every pathologist I know. But I was hoping to do like a soft rollout with you guys so that if you're interested in going through this, I'm beta testing this. Okay, so this is a normal neonatal kidney. I think this dog was like 5 days, I think. 5-day-old dog. And so you do see a lot of these structures in a normal neonatal kidney because cats and dogs are different than humans, and they have postnatal nephronogenesis. And so in a human kidney, you would never see this kind of nephrogenic zone, but in cats, dogs, and I do know pigs are the same, and I do know cattle are the same. I'm not sure about horses. I'll have to look into that. But anyway, this does kind of point out where the S-shaped body is and where there's an immature glomerulus, so that can help you kind of identify those structures. This would be an example of an immature/fetal glomerulus versus right over one field over in this dog's biopsy had a normal glomerulus. I do give advice for people who are pathologists that if you are concerned for maybe maldevelopment and you're like, well, I'm not seeing a lot of fetal glomeruli, I see a lot of strange glomeruli with dilated Bowman's capsules, but not fetal ones, it's actually very helpful to use the PAS because they pop out really easily with the PAS. And so all of these are the fetal glomeruli. So it ends up being a higher proportion if you are pretty good at, or if you could use the PAS stain. Anyway, I don't need to drag this on, just other than we did a lot of work on this. And a last feature that I'm kind of proud of is, and a lot of these will probably get expanded as we get more and more breed-related nephropathies figured out. But some of the juvenile nephropathies actually have more cystic change versus fetal glomeruli. And then I do like to make sure that pathology residents and pathologists know that the problem with having an abnormal kidney at a young age is that you will have fewer nephrons than maybe your sibling litter mate. You know, maybe you're the only one that was messed up, and so your litter mate has a normal number of nephrons and you have fewer. That means that your nephrons have to work harder to filter the same amount of blood, and they often get larger. The glomeruli get quite large, and the tubular epithelial cells also get quite prominent and quite hypertrophic. And so oftentimes we'll see nephron hypertrophy. It's a compensatory process. And the problem is that if you are not used to looking at kidney all that often, and you get a sample from a 2-year-old or a 1-year-old dog, and you're looking to see why this dog had, I don't know, chronic kidney disease or maybe chronic azotemia, these guys will jump out at you. The really large glomeruli will jump out at you because they're enormous. They take up a lot of space. This one actually even has podocyte protein reabsorption droplets. He also has a synechia. So he's not a normal glomerulus to begin with. And so in this scenario, you would see this, and maybe your mind would go towards a membranoproliferative process. It looks hypercellular. So a lot of pathologists would have called this membranoproliferative. Some pathologists might have said that this was focal segmental glomerulosclerosis, which isn't actually completely wrong, but this is, you know, there's a little bit of sclerosis here at the hilus. But so this guy dries your eye, and you just have to make sure you're saying, well, that's really weird to have this kind of glomerulus in a 2-year-old dog or a 1-year-old dog. Then you need to go on the hunt for the tiny little glomeruli that are, you know, the evidence that this thing never developed correctly to begin with. So I've had a lot of times where I've had consults based on a glomerulus. I know this is hard to, I know I'm flashing between things, but I've had a lot of consults from cases that the pathologist was worried about MPGN, and then they've overlooked the small little tiny hidden glomeruli, and they didn't realize that this is just compensatory hypertrophy and not a immune complex driven disease. Obviously, very important differential diagnosis because one would be immunosuppressed and the other one is going to be slowly chronic progressive. And then we did this. I'm going to maybe try to make this a little bit larger now that I see it in the text. It might need to be larger, but this is so much fun. I want you guys to see this. I think I can make this big screen. So we kind of did a little interactive how you can diagnose kidney disease, and based on what the histology shows you, would you see global glomerulosclerosis, a really high UPC based on the clinical picture. There's not even, you might find one or two fetal glomeruli, but not many. And then you pretty much need to do EM in that scenario. The UPC is quite high, so we think it's glomerular to begin with. And so let's say we saw GBM splitting or basket weaving on EM, then our diagnosis is Alport syndrome, and this is what it looks like. So you guys can play around with this if you feel like it. I was pretty proud of this because I worked really hard at it. I don't know how to exit though. Hold on. Oh, I can do this. Okay, there you go. So you guys, it's just a little bit interactive way to go through that. Okay, any questions from the chat or people who want to speak up to ask anything else about this press book? And also, if you still need the link, actually what you can do is just Google Renal Path Atlas. It always pops up as the first, but this is the link and I can send it to everybody again. It hasn't changed. Any questions? I'm gonna go look here, see if there's anything. Let's see who's on the, oh, we got one more person joining. Who is it? Why isn't it showing me? Manage participants, oh, okay. Oh, hi Cedric. I have your, I hope I gave you back your report back from those English, were they English Springer Spaniels that had probably renal maldevelopment? I think that's what they were. Your report should have gone back to you. Okay. Oh, thank you. Thanks. And that is the link. And since this is recorded, I think that gets recorded as well for the link to the press books. Like I said, Candace, I think I'll probably change the downloaded version this weekend and then send an email out to everybody so that way you can have it. Although I do want to say these interactive features can't be used with the downloadable version. Okay, so we have one case request, and it looks like we actually have a couple of clinicians and a couple of pathologists, so it's a good mix. Dr. Swales, correct me, you're internal medicine, getting ready to take boards, or you just sat boards? If you can type, I'm not sure, it's you're unable to speak. Oh, boards in March. Okay, sounds good. So I'm going to get the slides ready. Maggie, are you able to speak a little bit to the history of the case, or would you like me to pull up the request on VADS and VetStar?
I can talk a little bit about it, but you definitely would have probably more readily available the urinalysis
Okay.
and biochem abnormalities. So we received this dog. Oh, now I need to look up the signalment. I was not prepared. I apologize. But as I looked that up, we received this dog on autopsy, and it was an adult dog, and it was the second one within the household. It was a beagle mix to actually die of acute renal failure, and that's all kind of we got some more information. Thank you. And so what we later found out was that a third dog, a younger dog, of it was just told as a puppy to us, actually presented with acute renal failure after Shelby, our dog. And so a total of 3 dogs in the same household presenting for acute renal failure, and 2 of those 3 had died. And so as you can see here, there was hypoalbuminemia, azotemia, They did a thorough workup where they saw like a UPC of 11.5, and they did, they sent to IDEX, I think, or Antec. They did a thorough workup for tick-borne diseases as well as lepto. This says that lepto testing was pending. It came back negative, and everything that they tested for Borrelia, Ehrlichia, Anaplasma all came back negative. I don't think the rickettsial, like a rickettsia was done though. So that's one thing I need to double check on. But yeah, so the owner was particularly worried about lepto because they do have a creek in their backyard with some stagnant water. So yeah, that's where originally everything was kind of clinically the bigger concern, at least until they got the lepto PCR back.
And quickly, Maggie, do you know if from my memory, the first dog that died was not autopsied, correct? This is the dog that we have to present is the only dog that has had an autopsy.
Correct.
And puppy is doing better or worse?
I still haven't gotten any information about puppy. I don't know.
Okay.
Yeah, I don't think MedVet has gotten information about puppy either. I hope he's doing better.
Okay. And then, do you know if these dogs have? I know they'll have like access to water and stuff like that, on their kind of rural area. Do they also have travel history? We don't think so, right?
Not that was ever reported to us, and our DVM is very thorough, and so I think she would have said something if that was a part of the history. Okay.
So, as I'm making sure here, we've got everybody, Sabrina has joined. Hello, Sabrina. Sabrina is one of our clinical pathologists, kind of based in Texas as well. So I think one thing that I like to emphasize to my pathology trainees and my, colleagues, the internal medicine colleagues, is that I think it would be very unusual for lepto to give you a UPC of 11.5. To me, that is, screaming glomerular injury, whereas we know leptospirosis should be a proximal tubular injury. We actually presented a case a couple of months ago that was also a dead autopsy specimen from a dog that was concerned lepto. And when I got the histology, it was an MPGN type pattern with a few crescents as well. And so we presented it at kidney rounds, and I think we threw out the question of how bad could a UPC get in lepto. I mean, I think J.D. Foster has said he had one dog that had a really elevated UPC with lepto, but they never actually were able to get tissue from the dog to see if there wasn't also additional glomerular injury in addition to the documented leptospirosis. And I think one other person said that they've seen elevated, some degree of proteinuria with lepto, but in general, leptospirosis doesn't really cause severe, this is nephrotic range proteinuria. George, do you have other?
Let me chime in. It's the exceptions that prove the rule. In my recollection, I had two different cases that I'm convinced were sick principally of leptospirosis that had UPCs that would in themselves be suggestive of glomerular disease. One that I did the most work with, and she remembered and everything, was a dog whose initial UPC was 8.5. And I was thinking she probably had glomerular disease, and we had her in ICU. We were treating her and we were doing stuff for her. And the next UPC was like 3 or something. I mean, it'd fallen really quite a bit. And we were testing her, and it turned out she had lepto. And I believe, well, let me set that one aside and tell you that I had a dog, I think it was a bulldog, who was had very intense florid leptospirosis. His urine was inflammatory. He had a terrible nephritis, okay? And inflammatory cells and debris in his urine and things, and his UPC was 40. Now, the thing about UPCs is everybody always wants to think of them in steady state, but if you're not in steady state, then the excretion of creatinine and the excretion of protein may be out of sync with one another. And the other thing is, I believe that these are examples of proteinuria that's really interstitial, largely interstitial in origin, with the acute interstitial inflammation and damaged tubules and leakage of interstitial inflammatory fluids, including the proteinaceous portions of that, into the tubules and being washed down, that it's not necessarily glomerular in origin just because it's a big number. But it is the exception that, and I think it's very few cases and things like that. My counsel is to try to see. I used to fly airplanes, and one of the things that my flying instructor used to tell me was scanning, so that you didn't look at just the airspeed or just the artificial horizon or just, I mean, you had to believe at all of this information and, you know, round and round and round in the cockpit and outside, and gathering that information and continuously integrating it into, you know, whatever picture made the most sense with all the data that you had. And so I'm not a big fan of rules that, you know, if it's lepto, it can't be, or if it's UPC is 11, it can't be lepto or anything like that. But occasionally circumstances conspire to have a number that is at least on one occasion in each of these two dogs big enough to go, wow, you know, but it was lepto.
Has anybody else, I guess any of the other clinicians that, that deal with these types of cases, what's your feeling about UPC and leptospirosis? If anybody can speak. I'm not sure if everybody can type or has access to a microphone. Okay. Well, I'm assuming
I think
no.
my point is really that the big UPC doesn't have to be glomerular. I'm not saying that lepto causes glomerular disease. I'm saying that the protein can get into the urine otherwise if the interstitial inflammation is bad enough.
Okay. So we have a comment, have occasional cases with UPC in the 7 to 8 range, and they usually have AKI. One case was 15. Sorry, I guess I don't know what records. I don't know if this is the one that records versus how things get recorded in this. But okay, so it's kind of, as George says, the exception to the rule where you would have a UPC that has been elevated. And I'm not 100% sure whether we know whether dog number 1 that also died with acute kidney injury had a UPC performed. It might have just been the fact that they knew that the animal was in acute renal failure. So it would be really interesting, and I know that Maggie is still working on pursuing this case to see if the other dog ever had a urinalysis, because that dog died 2 months ago with acute kidney disease as well. And then also knowing what's going on with the puppy would be interesting. So I do want to show you the histology as we kind of look through the sample. So, although of course, oh, here's the slide, sorry. All right. Hopefully everybody can see the image now. Let me know if there's problems seeing the image. You should have an H&E slide being projected. And so both kidneys look very similar, and we can get patches of blue throughout the cortex and even into the medulla. So this is going to be our components of interstitial nephritis. And then the other thing that's going to be quite striking is that all of these pink things are glomeruli, and it's going to be easier to evaluate them on other stains. But I do want to get you guys a little bit of observing about where the interstitial nephritis is located. We kind of have it at the corticomedullary junction. Down here in the papilla, and I'm pretty sure part of contributing to the AKI in this patient is pretty much the entire papilla has mineralization of almost every single collecting duct. So that's probably driving a lot of the fact that that this animal has a pretty bad azotemia. Also, the glomeruli are kind of shot, and the tubular system is full of inflammatory cells. But both kidneys are very similarly affected by this interstitial inflammation. The thing that was kind of drawing Dr. Martinez's eye, and Maggie, is it cool that I drive and present, or did you want to present the glomerular features? I'm assuming since you're not here, you're calling in from home with the strep throat.
No, please go ahead and drive and present everything.
Okay, so so there's a lot of glomeruli that are just a titch that are globally sclerotic and basically ineffective at any sense of filtration here. So this glomerulus isn't going to do anything. But we do have, and then we have some areas where they might have a few open capillary loops. And you really have to search for these glomeruli that have at least a certain number of open capillary loops. And what I think was kind of striking first on the H&E, which made Dr. Martinez say maybe this isn't just a traditional lepto case, is that the capillary loops are often obliterated or effaced, and sometimes it's by eosinophilic material, so whether or not that's matrix or protein, maybe plasma protein. There's often some eosinophilic material in Bowman's capsule. Some of these guys with the kind of more open nuclei are going to be podocytes. Regarding cellularity, it varies. We often, or the rule is that you can have 1 to 2 endothelial cells per capillary loop. So for example, this capillary is fine. He's got 1 single nucleus. He's great. But you don't want to have more than 2 nuclei. And so for a lot of this, it's hard to see where these nuclei are located. Is this group in a capillary loop? It's hard to say. So that's why we're going to get special stains for this guy. But the other rule is that you can have 2 to 3 mesangial cell nuclei. And so if we look over here into this region of mesangium, we at least have 5 to 6 nuclei. So there is some degree of hypercellularity. There's a lot of effacement of capillary lumens. We have a lot of prominent podocytes. They're kind of have glassy nuclei. Some of them look like they're falling off. And then there's some material in Bowman's space. And one other thing I want to touch on for on the H&E slide is this feature here. Do you guys see all this kind of basophilic linear to stippling of Bowman's capsule? So that's all mineral. And I, anecdotally, whenever I see mineralization of Bowman's capsules, though that is not a good prognostic feature. Basement membrane mineralization is also not great, but usually, I mean, nobody's tested this, but usually we think this could, I think this would happen at an earlier stage of disease or maybe a less degree of hypercalcemia. And it has to be pretty marked hypercalcemia or hyperphosphatemia in order to get this Bowman's capsule mineralization. I've never tested that hypothesis. It's just whenever I see this, the dogs don't do well. All right. But you get this perception that every single glomerulus is affected by some type of damage. This isn't just a one glomerulus was affected with focal segmental glomerulosclerosis. This is a all-out, every single glomerulus is either looks like this or is completely sclerotic. The tubules also look bad. There's a lot of attenuation, kind of loss of the apical brush border. So these are all supposed to be proximal tubules, and we don't have anything in the lumen, and that's because all the apical brush border has been lost. We have a little, obviously something has died because we have a mitotic figure here, and he's trying to replenish the tubular basement membrane, the tubular epithelial cells. And so pretty much every single tubule is shot. The kidney does some really cool stuff. When epithelial cells die, they can detach, and they will actually look like either viable, like this guy, or apoptotic cells like this guy. And so they actually can detach and undergo anechis, which is that they maintain viability. If they got peed out into the urine, we probably could culture this guy up, but these guys would have been dead. So it's just the way that the kidney can undergo death. But you can see that it makes sense that these guys are hanging out in the lumen. We have this huge region here where there's really no good nuclei. These cells, this cell over here, and that cell right there are probably spreading out their cytoplasm in order to cover denuded basement membrane. And these guys are the dead ones in the middle. Tubular necrosis, very, very common with a really rip-roaring glomerulonephritis. Interstitial inflammation is also very common with a rip-roaring glomerulonephritis. So these things, these features here are not surprising when the or it's a little bit easier for us to use that stain to estimate cellularity. And if you guys who are new to kidney rounds haven't figured it out yet, I talk really fast. So if you need me to slow down, just tell me to. Oh, goodness. Actually, I've looked at the other stains, Maggie. I haven't looked at this particular stain, so I'm going to do a little bit of a once-over. Oh, yeah, this is a good place. Let's land here. This warrants discussion. Okay. So this is the PAS. Now, this stain really helps the pathologist figure out where nuclei are located. Are they located in a mesangial region? Are they located within the lumen of a capillary? Or are they located outside the lumen and are therefore probably a podocyte? So if we focus on this region here, we can see that this used to be a capillary loop, and it probably still is. That's probably the endothelial cell, maybe that thing. But we have these polymorphonuclear cells hanging out in the lumen, and we have about 4 or 5. So my rule of 1 to 2 is already broken. This, I'm not sure if this is in Bowman space, but there's a whole bunch of polys in here as well, polymorphonuclear cells. So if this might be in Bowman space, or it might be that we're just kind of having a very small bit of capillary basement membrane here, it's hard to say. I kind of almost think it's in Bowman space. So even having just a few loops that have evidence of activity, so this would be evidence of activity of ongoing damage, whereas you know, some of these areas look like they might have been damaged a long time ago and now have a whole bunch of protein pushed into their wall. So these are probably areas where plasma's been pushed, and so that would be maybe a previous region of damage. And then also look at these podocytes. This podocyte is amazing. This little clear space here is oftentimes what we see on electron microscopy, and we call it like a pseudocyst. Basically, it means that podocyte cytoplasm is basically wrapping around and engulfing a huge region of urinary filtrate because they're so damaged. So we have these huge kind of vacuolar structures in them. Here's some more. There's protein droplets in parietal epithelial cells. We have adhesions between the glomerular tuft and Bowman's capsule. And then we still have some degree of mesangial hypercellularity with about 5 nuclei in that segment and about 8 nuclei in that segment. So hypercellularity is there. It's pretty, it's patchy. It's not in every single glomerular tuft. And I would probably bet it was a little bit more significant in the past. And now we're kind of seeing like the end result. We're seeing that like the final result of previous really bad glomerular damage. It's quite gorgeous. You guys want to see that podocyte right here, which is full of protein droplets. And we have some segmental hyalinosis, some segmental sclerosis, really good synechia. And so maybe this glomerulus was injured even previous to that. Again, if you kind of just scan over, and again, the PAS is going to be so great for us to get to where it's going to help us easily identify all the glomeruli that have been lost to the injury. So it's going to be better for you guys, if you guys are doing a count of glomerulosclerosis, do it on the PAS stain. because these guys are going to jump out at you. If you guys were looking at the H&E, this would be just a small region of pink stuff. It really wouldn't be as prominent fuchsia. And so this guy was a glomerulus, that guy was a glomerulus. Look at how many are already dead in this field. So PS is also good for us to assess brush border. You should have a really prominent brush border. I'm not sure I'm going to be able to find a healthy tubule in here for you guys to see the prominent brush border. Looking, yeah, pretty much everything. Maybe this guy. Even this is a little bit. Maybe this one portion of this nephron is probably doing all the work. You can still see a brush border in this guy, in these segments of the nephron, but if you go to most of the segments, you're not going to be able to see a brush border. So pretty much maybe that one single nephron is doing all the work of the kidney. Let's see. Then we're going to move over to the trichrome. The trichrome was cool. Maggie was actually questioning whether or not there were crescents in the kidney, and at first, based on the H&E, I wasn't sure. I didn't really see a lot. I did catch a few in this trichrome stain, so I'm going to try to find them if I can. So, yeah, here's one. And it's actually probably a little bit more very small areas, but this is what would happen if, let's say, the glomerular capillary loop had ruptured and everything that was in circulation in those capillary loops got spilled out into Bowman space. What you get to see is this bright red material. So here's the glomerulus. Here's another segment of the glomerulus. And all this bright red material is fibrin and protein and, you know, some cells in here and plasma. Everything gets pushed out into Bowman space. So there are some very small segmental crescents in here. That implies extreme damage to the glomerular tuft. You can get some crescents at Bowman as well if Bowman's capsule breaks. You would get crescents as well, but this one is a pretty good active crescent right now. It's a good catch, Maggie. A lot of the red in here, it's hard to say whether or not this is just fibrin, whether this is plasma, or whether these are immune deposits. I think the brightness for me suggests fibrin, and we will see fibrin accumulation and fibrin tactoid formation in really bad glomerular disease that would have obviously how do I want to say this? We'll see really bad fibrin tactoid formation in a process where the endothelial cells are damaged, and we call that process thrombotic microangiopathy. So I think that this one has kind of both situations going on where we have really bad glomerular disease. I lean towards immune complexes based on how messed up the glomeruli are and how frequent immune complex disease is in dogs. But then we have areas where there's a lot of fibrin accumulation, and even the mesangium starts to dissolve a little bit. So whether or not this is immune complex disease with superimposed thrombotic microangiopathy, which is what I favor, or whether it's just all fulminant thrombotic microangiopathy, which is the second possibility. It's hard for us to say. I do think that we asked the owner if the owner wanted to do electron microscopy, and we were hoping that they would want to do electron microscopy. It would tell us whether or not we have immune complexes. We would still see electron dense deposits in this dog. It would also, hopefully, if we got a glomerulus like this in the field where we had a lot of this bright red, orangey material, to see if there's true fibrin here, we would be able to evaluate the endothelial cells in this region. And we could maybe catch a few of the diagnostic criteria for TMA or thrombotic microangiopathy. So basically, it could tell us between one versus whether this dog has just one disease or two diseases. The question that they're trying to communicate to the owner is it's not going to tell us what the immune complexes were directed against. We did have a tick titer test, a SNAP4 test that didn't show any underlying tick-borne disease. So we won't know what the antigen was if we find immune deposits, but we could at least say that it's immune complex mediated. The weird complex thing is that multiple dogs in this household have been a diagnosis with kidney disease. And so it's really hard for us to put all that together, because immune complex disease really shouldn't be a multi-dog household phenomenon. That being said, I've had 2 dogs that were diagnosed with Lyme from the same household. Are there any comments or questions about the trichrome stain? Here's another little region where we have a little bit of a crescent in Bowman space as well. I was looking for red deposits in the capillary loops. I can't really see them. It doesn't mean they're not there. It just means I can't really see them. I will then show the silver stain so I can show you the remodeling of the glomerular base membrane.
Warned there were 2 silver stains because like we just preemptively also did a orphan story. So just, yeah.
I know which one to pick up.
Sorry.
No, yeah, they did a Worthen Starry, and that was negative for any leptospires. Although I had a really hard time seeing leptospires, even on a Worthen Starry. Okay, so I'm at 60x. And so one thing we use this stain for is to look for evidence of remodeling glomerular base membrane. So this is a normal glomerular base membrane. That's the normal thickness right here. And we can compare this to maybe a normal tubular base membrane. I know this isn't a greatly normal tubule, but it's in the field. But you can see this is probably a normal thickness of a normal tubular base membrane, which is the same as the GBM, so that's fine. But then when you come to here, we have areas where we have multi-lamination. We have a little bit of double contours. We have a dark layer, a little bit of a lucent layer, and then another dark layer. And so it varies. Some capillary loops look normal, and then other of them look somewhat remodeled or very remodeled. And so usually when we see remodeling of the GBM, we think this remodeling is due to immune complex deposition. TMA technically can remodel GBMs, but again, TMA as a standalone disease is so rare in dogs, whereas immune complex disease with superimposed TMA is more frequently diagnosed. So if you're going down the percentages, I would still think this is immune complex based on the frequency it happens in dogs. And then the fact that we have a lot of areas of endothelial damage and some fibrinoid tuft change or fibrinoid tactoid change in the glomerular tuft, that there's likely a superimposed TMA on this. TMA can be due to a lot of things. Could be that this dog was severely hypertensive at the end of life, and so he blew out a lot of his capillaries. We know in the greyhounds, those racing greyhounds, that it was due to Shiga toxin, and that directly attacked the endothelial cells. Endothelial cells died. The TMA in those dogs is usually a little bit more at the base of the glomerular tuft, similar to the dogs we have in the UK, Dr. Swales, that are the ones that have a skin rash or a skin injury, and then they go into AKI, and they have a pretty bad rip-roaring lesion, mostly at their vascular pole of their glomeruli, although it does also damage the endothelial cells out in the peripheral capillary loops as well. So, and that's that UK. We still don't know the cause, thrombotic microangiopathy lesions. But I guess if you were throwing around ideas for why multiple dogs would have been affected, I don't think we've seen any of these of the UK dogs that same disease happen, or that same phenomenon happen in the United States. But maybe the clinicians have more information if it jumps the pond. Does it still seem to be mostly United or UK phenomenon for those weird AKI dogs with CRGV? That's what it is. Cutaneous renal glomerular vasculopathy. It's a TMA. Anybody else seen any of those dogs other than the UK? Okay, I'm assuming not. George, do you also kind of favor an ICGN based on this?
I'm not sure. Something has done extensive damage in all compartments. One wonders about hemolytic uremic syndrome in people is another, E. coli, toxins and sugar toxins and a variety of other things. I mean, there's more stuff than we understand out there, and I don't know what this is, and having sort of piecemeal information about other dogs, but not, you know, equivalently detailed information about each. We don't know how really comparable they are, and people tend to lump things together and make assumptions that may actually be totally accurate, but you don't know. And so this
Do you think this is lepto?
Probably not. Not lepto. I mean, lepto doesn't do to glomeruli what's gone wrong with this dog's glomeruli. So it's not leptospirosis. Certainly not as a single disease. I don't want to give the dog two diseases. So something.
I don't know if anybody
do we
else
have IF and EM on this dog yet?
No, we've asked the owner if they would like to pay for EM. We'd actually, one other thing, we tried to get urine. They tried to harvest urine at autopsy, but I think like the tiniest drop was, so it was probably all uric by the time it was euthanized.
Yeah, sure.
So we didn't get any urine to run the SDS page. Also, we have kidney that was frozen, but they froze it in the hopes of doing tox analysis.
Yeah. So
yeah, and so I mean, I guess we could try to thaw it and embed it in OCT and see whether that works. But if it doesn't work, it doesn't mean it's not there.
Well,
I don't know if anybody.
I'd go by EM anyway, so
okay.
Given the circumstances.
Okay. Well, hopefully the owner will decide. And I try, my best to like support, I'll just cover the costs and stuff like that. But it's hard to say when we really don't have the whole gamut of, a piece of information for Hokam's SDS study, that kind of stuff. So, Maggie, do you have any other questions as we wrap up about this case, other than just being like, yep, we all, or some people looked at it and they favor it's not lepto, and then it's more of a glomerular-driven process.
I guess, so yeah, one of the things that the clinician was asking us is, are we doing EM for academic sake, or what can we actually learn from it? AKA, how much do I pressure the owner into spending $300? Would it, I guess, from everybody's point of view, how beneficial is this EM in order to help us, for this dog alone, diagnose like a TMA, sugar toxin, whatever weird glomerulopathy versus the immune complex?
Well, if it's immune complex, then there's some genesis of antigens and antibodies, whether they're autoantibodies, but in a family or a sort of a outbreak kind of thing, one would think in terms of some sort of infectious agent, whether we can find it or not, or it's showed up and it's in the testing that's been done before. But one would think in terms of that category of things, often in one totally different direction than if there's all this glomerular damage and no immune complexes or complement. There are kinds of these dogs in this family are related or not related. This is a household of unrelated dogs, or are they related to one another in some way, or do we know?
We don't for sure know, but I believe they're unrelated, just all in the same household.
Well, there are some really bad things that can happen to glomeruli because of genetic abnormalities in the control of the complement cascade, so that you can have complement-mediated glomerular injury without it being activated by antigens and antibodies, or the sugar toxin, or whatever happened to the dogs in UK. What they used to have it happening in the greyhounds in the United States in the racing community. They called it Alabama rot, and it was largely in dogs that were fed raw meat because it made them run faster. There's stuff out there that.
Okay.
But so the EM would help categorize the mechanism of the glomerular damage in a way that would point us, if not to a specific final diagnosis of the original cause, but at least have us looking in the right direction. You know?
Okay, I can sell that because from there, it would be. Could we use the little bit of frozen urine and frozen kidney to then, after EM, pursue, I know it's going to be hard in a lot of these cases, but pursue what the inciting cause would be, or pretty much EM might, yeah.
Yeah, so one quick thing though, Maggie, is if they're deciding what to spend money on, maybe getting more information from the dog that's still alive would be better.
Yeah.
And if the other dog has, proteinuric kidney disease, and maybe a biopsy of that would be a better sample than what this is. And then also we don't really, other than being able to say it's ICGN and then historically putting it with the fact that the animal had a tick-borne disease or the animal usually it's tick-borne. If we don't find tick-borne infections, then we don't really often know what the situation was. But we literally, it's just one of those, we get to the fact that there is some kind of immune complex deposition, and then we say if you can't find an infectious agent, then it's probably directly autoimmune against almost like a lupus scenario. But at this point, we don't do well about figuring out the subsets like they can do in human medicine. I wish we could do that. And, that's the goal of the research, but we don't have it yet.
The pathology never tells you exactly.
Yeah.
I mean, we find the antibodies, we don't find the antigens. We don't, So, and in human medicine, they have a whole, when you go to a renal biopsy conference at a medical center or something like that, the clinicians talk for about 10 minutes about all the serologies they've done for autoimmune and lupus and double-stranded DNA and it's negative or it's positive or right of this stuff. And I always just sit there and wonder about what's in the fog that I can't see through about dog disease, because we don't have the same tools.
Okay.
And I'm not really complaining. I'm explaining that there are possibilities that we can't know about. Nobody understood infectious disease before Leon invented a microscope. I mean, it was a mystery. You have to have the tools to see the determinative findings that allow you to go, eureka, there it is. And we don't have them comprehensively. But we know more today in, nearly 2020 than we did in, 40, 50 years ago when they handed me my veterinary degree. So, it'll get better.
No, yeah, no, it's helpful.
So yeah, and then one other thing is just make sure that we don't lose that frozen kidney, because it would be great if at some point we do develop a test. So don't lose the frozen kidney and I know we have very limited urine, but make sure it goes from the regular fridge where we put the tox samples, maybe into my fridge up in the lab, and then make sure we don't lose the formalin-fixed kidney. And we can use it for other stuff, or it would be useful for other stuff. We are about right at noon, right at 1 p.m. So I'm glad that people were able to call in, and that people didn't seem to have issues with the Zoom format. I do know JD did text me or sent me an email about a case, or he already has cases planned for September. October. He wasn't able to attend because he's on vacation, I think, this week or somewhere in England. But there will be kidney rounds almost definitely next month. And if there is any follow-up from that case, I'll make sure I present it next month as well. Thank you guys for calling in. Let me know if you have any questions. Go check out the atlas. And if anybody ever wants these versions that are taped, I have access to them, and I can give you guys all the recorded seminars if you want them. Thanks. Is that good for everybody?
Bye-bye. Thank you.
Okay. Bye.